I'd like to now introduce our next speaker, Dr. Jennifer Lai. She's a transplant hepatologist and associate professor at UCSF, where she is dedicated to improving quality of life for her patients by incorporating core principles of geriatrics into the care of her patients with cirrhosis. She's a PI on an NIH-funded study, which aims to evaluate physical frailty and functional status outcomes before and after a liver transplant. So we're very fortunate that she's here tonight to teach us more on this topic. She earned her MD MBA from Tufts, completed her residency at Columbia, and her GI and transplant hepatology fellowships at UCSF. Welcome, Dr. Lai.
Thank you for the opportunity to present this talk to you today entitled Frailty in Patients with Cirrhosis, From Recognition to Reversal. I'm certain that we have all cared for patients with cirrhosis in whom frailty was a major contributing factor to their death. For example, if only your patient hadn't been so frail, maybe he would have survived his episode of SBP, or another patient would have survived to transplant. And there's now a substantial body of literature to support this clinical intuition. Frailty has been found to be associated with a twofold increased risk of waitlist mortality, greater risk of hospitalizations and mortality after hospitalization, poorer quality of life and subsequent disability, as well as a higher risk of mortality and poor functional recovery after liver transplantation. If a picture were worth 1,000 words, this is how I would portray it. Frailty is essentially a patient's physiologic reserve, and I want you to think of two patients who are similar by all characteristics except for their amount of physiologic reserve, with the frail patient having much less physiologic reserve as the non-frail patient. Both of these patients are subjected to an acute stressor. Now, the non-frail patient will experience a transient depletion of their physiologic reserve in response to the acute stressor, but once that stressor has been removed, they will experience a gradual repletion of their physiologic reserve and get out of this event without significant complication. On the other hand, a frail patient will also experience that decline in their physiologic reserve in response to the acute stressor, but be pulled below the threshold of adverse outcomes, where they experience one complication after another, such as acute kidney injury resulting in need for hemodialysis or hospital-acquired pneumonia, and really never be able to replete their physiologic reserve after this hospitalization, and are particularly vulnerable to death. Frailty is not a construct that is specific to patients with cirrhosis, but was actually originally developed in the field of geriatrics and is most commonly formally defined as a distinct biologic syndrome of decreasing physiologic reserve and increasing vulnerability to health stressors. In the geriatric population, frailty results from the combination of chronologic aging, progressive immobility, and comorbid factors. But in patients with cirrhosis, there are a number of additional factors that are specific to the cirrhotic state that accelerate this frailty cycle, such as hepatic synthetic dysfunction, portal hypertensive complications, chronic inflammation with resulting hypercatabolism, and malnutrition. For this reason, I would propose a modified definition of frailty for consideration in patients with cirrhosis, with frailty being the phenotypic presentation of the intersection between nutritional status, muscle function, and muscle mass. And we can use this tripart definition roadmap for reversal or prehabilitation in this population, and we can specifically target each of these three components of frailty to reduce death, improve function, and quality of life. The objective of this talk today is to help you acquire pragmatic skills to prehabilitate your patient with cirrhosis that you can implement in your practice today. Prehabilitation is formally defined as the process of enhancing functional capacity prior to surgery to improve tolerance for the upcoming physiologic stressor. In other words, it is equivalent to trying to give a frail patient more physiologic reserve in preparation for surgery, but it's not really specific to surgery itself. We can imagine for a patient with cirrhosis that it could be any acute stressor, such as an episode of SBP or an episode of an acute variceal bleed. I recommend a 3-step approach to prehabilitation: measure, intervene on muscle health, and motivate. Let's start with measurement. We all currently have a frailty assessment tool that we use every day in our clinical practice. That is the eyeball test. And while there are many circumstances in which the eyeball test is incredibly useful, it does have some limitations. It is subjective, variably applied from one patient to another, and it does not offer a lot of granularity and therefore limits our ability to follow patients longitudinally to assess for worsening or response to our treatment recommendations. Therefore, I recommend that we begin to anchor our frailty assessments using one of 4 tools in the Frailty Toolkit, as has been recommended by a consensus panel from the American Society of Transplantation. I will go into these 4 tools now. The KARNOFSKY Performance Status Scale is a very simple and quick scale that is assessed by the clinical provider or the patient and ranges from 100, which stands for normal performance status, to 0, in which the patient is moribund. Clinically relevant and prognostic cut points have been established in patients with cirrhosis, with 80 to 100 representing a patient with high performance status and 40 and below representing a patient with low performance status. And the KARNOFSKY performance status has been shown to predict 3-month mortality after hospitalization, mortality after liver transplantation, as well as waitlist mortality in children. Activities of daily living are the 6 activities that are necessary for basic functioning within the home and are assessed by the patient or the caregiver and consist of eating, bathing, dressing, transferring, toileting, walking, or moving around. The ADLs predict 90-day mortality after hospitalization and predict overall waitlist mortality in patients with cirrhosis. The 6-minute walk test is simply the distance walked in 6 minutes. It can be done very simply in the clinic setting and only requires a stopwatch. In patients with cirrhosis, this distance has been shown to predict waitlist mortality and is correlated with quality of life after liver transplant. The last tool for your frailty toolkit is the Liver Frailty Index, which consists of 3 performance-based tests: grip strength, chair stands, and balance testing, and takes approximately 90 seconds to complete in an ambulatory clinic setting. The Liver Frailty Index has been associated with adverse outcomes in patients with cirrhosis and is equivalent to about 9 meld sodium points of mortality risk. Studies have shown that the Liver Frailty Index enhances clinician prediction of death, is associated with current and subsequent patient-reported disability, predicts death after liver transplantation, and is the single predictor of functional robustness after liver transplantation. So now that we know how to measure frailty in clinical practice, let's begin to focus on intervention of muscle health. And here, again, I want to remind you of the roadmap using the modified definition of frailty being the intersection of nutritional status, muscle function, and muscle mass in patients with cirrhosis. When it comes to improving nutritional intake in patients with cirrhosis, recommended energy intake is greater than 35 kilocalories per kilogram of body weight per day, and recommended protein intake is 1.2 to 1.5 grams per kilogram of body weight per day. I find it useful to get a little bit more specific with patients and actually calculate out for them what their recommended energy and protein intake ranges should be per day. And in light of our ever increasing epidemic of obesity in our patients, I also recommend that you consider BMI modified cutoffs for daily energy intake. For patients with a body mass index between 30 and 40, consider a lower kilocalorie target of 25 to 35 kilocalories per kilogram of body weight per day. And for those with a body mass index greater than 40, a recommended energy intake of 20 to 25 kilocalories per kilogram of body weight per day. I have found that a lot of people don't know how many grams of protein are in a serving of food, so I like to provide additional information about common sources of protein to my patients. I tell them that a single serving of chicken or salmon contains about 30 to 35 grams of protein, one egg contains 6 grams, and one serving of peanuts contains 12 grams. When it comes to serving sizes, I further provide patients with the hand guide to serving sizes, where the palm of one's hand represents approximately one serving of meat or fish, the thumb represents a serving of peanut butter or cheese, a fist represents a serving of nuts or a carbohydrate. The timing of energy and protein intake is just as essential as the type of energy intake. Patients with cirrhosis have decreased gluconeogenesis that leads to increased breakdown of skeletal muscle to meet amino acid needs, which leads to accelerated protein energy malnutrition. In fact, the metabolic profile of a patient with cirrhosis after an overnight fast is equivalent to the metabolic profile of a healthy person after 3 days of starvation. And so, this is the reason why it's important to break the fast and give a meal or take in some energy intake right before bedtime. This concept of the late evening snack has been very well studied in patients with cirrhosis and generally consists of about 200 kilocalories of a late evening snack. And it can be 200 kilocalories of anything. These are the things that have been studied, such as a glucose solution, rice ball, regular food, a supplemental shake, or branch chain amino acid enriched supplement. Personally, I like to recommend a cup of Greek yogurt and a handful of nuts, or 2 slices of toast with low salt peanut butter, just to provide specific examples to patients. There's strong randomized clinical trial evidence to support the benefits of nocturnal feeding on body protein. These data come from an RCT of 52 patients with cirrhosis who were randomized to a daytime feeding arm and 51 patients with cirrhosis who were randomized to a nighttime feeding arm, defined as between 9 p.m. and 7 a.m. And you can see very clearly that the patients who received the nighttime feeding, as represented by the black column, experienced significant improvement in their total body protein at 3, 6, and 12 months compared to the daytime feeding arm. Now, what is so beautiful about this study is that the nocturnal feeds did not consist of anything special. It was simply 2 cans of an over-the-counter supplemental shake for a total of 710 extra kilocalories per day. So this is something that we can be implementing in our clinic and recommending to our patients immediately. Equally important to prehabilitation as nutrition is exercise, which is defined as activity requiring physical effort, carried out especially to sustain or improve health and fitness. I mention this definition because I think a lot of our patients feel like the leisurely walking that they're doing, such as walking their dog around the block, is sufficient to count as exercise, but it's really not sufficient to improve their outcomes. And while it's a great foundation, I think we need to do more to motivate our patients to push themselves. In order to do this, consider the FITT recommendations for exercise, which stands for frequency, intensity, time, and type. There are two types of exercise we should be recommending: aerobic activity, 3 to 5 days per week, 150 minutes total per week, and at an intensity of 5 to 6 out of 10. In order to estimate intensity of aerobic activity, I recommend the talk test to guide intensity, which is that patients should be short of breath but still able to talk and have a conversation. The second type of exercise that we should be recommending is resistance training, at least 2 days per week, if not more, and they can alternate upper and lower body days. And you can use the rep test to guide intensity, which is that patients should be able to do 2 to 3 sets of 10 to 15 repetitions. Consider actually doing some exercises with your patients, either in clinic or by video. Here are examples of 4 simple exercises that are very useful: the sit to stand, sitting knee extension, sitting hip flexion, as well as the wall squat. And finally, I send patients home from their visit with additional exercise resources, either in their after visit summary or as patient handouts. One of the best online resources I have found is wellnesstoolbox.ca, which stands for Canada, which was developed by one of my colleagues, Dr. Punita Tandon, and provides very specific and evidence-based recommendations for nutrition and exercise for patients with cirrhosis. Notably, this website also contains separate recommendations for patients with inflammatory bowel disease. There are also workout videos on the National Institute on Aging Go for Life campaign website. And the Otago Exercise Program is an evidence-based fall prevention program for frail older adults that is particularly useful for frail patients with cirrhosis in whom you're very worried about risk of falls. There is one pharmacotherapy that has been shown to improve muscle mass and therefore frailty in patients with cirrhosis, and this is the use of intramuscular testosterone for men. In a double-blinded, placebo-controlled, randomized clinical trial of men with cirrhosis and low testosterone, intramuscular testosterone given for a total of 12 months significantly improved lean mass at 6 and 12 months compared to placebo, and significantly decreased fat mass at 6 and 12 months compared to placebo. Now that we have discussed interventions to improve muscle health, let's focus on the last pillar of prehabilitation, which is motivation. I want to bring your attention to the nudge behavioral theory, which is supported by recommendations from the United Kingdom meeting on exercise and solid organ transplantation. Nudge behavioral theory encourages interventions that focus on changing the environment, including both social and physical aspects, in such a way to increase the probability of people performing a desired behavior without requiring those people to think very reflectively about it. So, in other words, you try to make it easy for patients to engage in these positive lifestyle behavioral changes. I have a toolkit for you called the MINDSPACE toolkit in order to begin to implement this nudge behavioral theory in your clinical practice. MINDSPACE is 9 coercive mechanisms to influence behavior and stands for messenger, incentives, norms, defaults, salience, priming, affect, commitments, and ego. In the interest of time, I'm going to focus on these top 3, although I do recommend that you look into this article and read about the other 6. M stands for messenger. While it is essential that we engage the help of dietitians and physical therapists in prehabilitation of our patients with cirrhosis, it sends such a powerful message when the primary gastroenterologist or hepatologist and or transplant surgeon emphasizes the importance of prehabilitation. This is not an optional treatment. It is standard medical therapy for patients with cirrhosis that is worth spending time on in clinic to discuss. I stands for incentives. We are easily motivated to avoid losses, favor immediate payoffs, and overweight small probabilities. Our patients remember the negatives more easily than the positives. My patients have told me that they worry about too much salt or too much protein or of falling. Rather, we should encourage the positive side of these behaviors. Add spice for palatability. We can offer minimum and maximum protein targets to aim for per day. We can encourage the use of a chair for balance. N stands for norms. We are strongly influenced by what others do. Let's make it a habit to prescribe nutrition and exercise as a standard treatment for all patients with cirrhosis, akin to antibiotics for SBP prophylaxis or Q6-month liver imaging for HCC screening. And that is the 3-step approach to prehabilitation for patients with cirrhosis in real-life clinical practice. Thank you very much.
Great. Thanks so much, Dr. Lai. We have a few questions. One is, do you routinely recommend testosterone supplementation? And any concern for promoting development of HCC?
So I have been trying to routinely check testosterone levels in patients. I think there is certainly a theoretical concern about the risk of promoting HCC, but the randomized clinical trial that I did show you that I showed you in the talk, did look at the risk of HCC development, and there was no increased incidence of HCC. Now, of course, it was only a 12-month study, so we don't know, and they did exclude patients with HCC. But I will say that this is a rather popular therapy among patients with cirrhosis. My men with cirrhosis definitely want their testosterone levels checked. They show up for their appointments to follow up on their labs. They show up to their endocrinology appointment for low dose repletion of their testosterone. So it is a therapy that they will adhere to much more than they will adhere to diet and exercise. So it's something that I have been increasingly trying to check.
Okay, great. Another one is about the patients who seem to have recurrent admissions or prolonged admissions, spending more time in the hospital than in the outpatient setting. What kind of strategies do you have for these patients who seem to kind of decline more rapidly due to those circumstances?
Yeah, that one is a really tough one. Certainly, a hospitalization and acute illness can cause rapid decreases in their muscle mass and their muscle function. And quite honestly, I would say that at that point, it's getting to be too late to intervene. I mean, sure, you can get physical therapy on board, but of course, physical therapy, can only be there for 30 minutes if they don't miss them while they're at ultrasound or at a procedure, and tube feeds can only go so far. And that's why I have really been promoting the management and the assessment and the management of frailty and malnutrition and sarcopenia in the outpatient setting. We have a really prime opportunity to detect any evidence of frailty really early on in the outpatient setting, such that when they get to the hospital, they have some physiologic reserve to withstand that hospitalization. If they're frail going into the hospitalization, it's going to be really difficult for them to bounce back.
Yeah. With regards to late snacks or evening snacks, do you have any inpatient protocols to help address that?
Yeah, I saw that, Will. I wish we did. We don't have any protocols. I think it's a great idea. My personal practice is that if a patient is undergoing a procedure the next day, I tell the patient to actually order an extra yogurt or an extra supplemental shake, and they put it by their bedside. And at 11:55 p.m. before they go NPO before after midnight, they actually take in that shake or they take in that yogurt. I will admit not a lot of them do that, but they do know that, at 9 o'clock at night before they go to bed, they should definitely try to eat that, not stop eating at 6 p.m. when their dinner tray comes to them. We really do try to, if we know, for example, our right heart caths for our elective procedures definitely don't happen till the afternoon. So we'll actually stop the tube feeds at 6 a.m. rather than at midnight. It's a lot of just internal knowledge of your own system, but as much as you can push that NPO time to 6 a.m. or 4 a.m., uh, the better. We also in the hospital have made available a hot late evening snack. And so our nursing staff actually was able to negotiate with the cafeteria to get one late evening snack, and it happens to be spaghetti and meatballs, which would not have been my first choice, but it's better than nothing. And so we do actually have a hot late evening snack available for our patients.
Okay. It's a good idea. We have a couple of questions from Dr. Kamari. I guess going back to your testosterone question, what's the max dose and starting dose, and do you check levels before starting?
Yeah, it's a great question. I don't actually do the actual management of testosterone. I send them to endocrinology. And the reason is that every time I have checked testosterone levels myself, the endocrinologist says, well, did you do it at the right time? Did you check the sex hormone binding globulin? There are so many other things, the free testosterone, the bioavailable testosterone, the time that you checked it. And so there's so many aspects and there's so much finesse to repleting testosterone that I actually refer to endocrinology.
Okay. I think there is another one. At UCSF, what are your lowest and highest BMI cutoffs for transplant?
We are moving away from specific BMI cutoffs. So we used to, I think the traditional BMI max was 40. And then after above 40, it's a lot of, eyeballing and let's see the patient. But I think that, first of all, our patients, with obesity, all of us are managing patients with ever increasing obesity. So if we really did set it at 40, we'd get fewer and fewer patients in our transplant practice. But also, the data are increasingly showing that BMI is not a relevant predictor of mortality, but actually function is. And so, since we implemented the Liver Frailty Index assessment in our patients in the outpatient setting, we have found that the frailty index is much more helpful in determining whether the patient, especially when they're at the edges of BMI. So if their BMI is really low, like 20 or lower, their BMI is 40 or higher, it's much more, or their BMI is, I would say, 45 or 50. Knowing their liver frailty index is very important. So if their BMI is 48 and they're very robust, well, we're going to go for it. If their BMI is 48 or their BMI is 20 and they're frail by the liver frailty index, by their grip strength, chair stance, and balance testing, then those are the places that we will defer them for prehabilitation.
Great. Well, there's a lot of interest in dosing testosterone.
Yeah.
So, if you don't have access to an endocrinologist, what recommendations do you have for supplementation?
That is a good question. The I wish I could remember. I actually have a number in my head of testosterone, but I'm a little bit worried that's the wrong number. It's intramuscular testosterone. I would recommend looking up that J Hepatology paper by Marie Sinclair, because the dosing is there. I think it's intramuscular testosterone. I thought it was 1,500 micrograms or something like that every month, but don't quote me on that because I really have not been in the practice of prescribing it myself.
Great.
I think Dr. Reutman had asked about HCC, which gives me less pause than portal vein thrombosis. Portal vein thrombosis really, portal vein thrombosis and testosterone makes me nervous, even though that RCT did not show an increased risk of PVT. But I would make sure that the patient has had recent liver imaging and does not have portal vein thrombosis before starting.
Great. Well, thank you. Thank you so much, Dr. Lai, and thank you to our other speakers, Dr. Singh and Dr. Frederick. And thanks to our audience for sticking with us